Imagine walking into a mechanic shop for like a routine oil change. Your car's running perfectly fine, maybe making a tiny, barely noticeable hum at high speeds.
Right.
And you ask the mechanic to take a look, and they suggest that just to be absolutely safe, you should probably tear out and replace the entire engine block.
You'd laugh in their face.
Exactly. You would immediately walk out of that shop.
Yeah.
You would never agree to that level of permanent destructive intervention for a functioning car.
No, of course not.
But right now, inside clinics and hospitals all over the world, millions of people are asking for and sometimes receiving the exact equivalent to their own bodies.
Welcome to the deep dive. Today, we are looking at a stack of medical guidelines to answer one critical question. How do you avoid overtreatment when your anatomy is technically perfectly normal, but you're dealing with, real physical symptoms or aesthetic concerns? It's honestly one of the most complex dilemmas in modern healthcare right now, because we possess this phenomenal technological toolkit today. I mean, we can scan, we can biopsy, we can surgically alter almost any tissue in the human body.
Which sounds like a good thing, right?
It is, but the hardest question a physician faces isn't how to perform those interventions. It's knowing when to keep the scalpel in the drawer.
Yeah.
There's this incredibly powerful human instinct to just fix things the moment they cause us distress. But when we intervene on a body that is fundamentally structurally sound, we run an outsized risk of creating a brand new permanent disease in our quest for a cure.
So to understand how to protect yourself from this, we are synthesizing some major sources today. We're pulling from the British Medical Association's Ethics Toolkit, the NICE Guidelines on Heavy Menstrual Bleeding, the British Menopause Society's Protocols on HRT, and surgical guidelines from the Royal College of Obstetricians and Gynecologists.
That's a lot of ground to cover.
It is, but running through all of these documents is this global initiative called Choosing Wisely. The core philosophy there is getting doctors and patients to stop doing tests and procedures that offer no concrete evidence of benefit or that, actually cause harm.
Exactly. And to really understand how overtreatment happens, we have to start at the absolute baseline.
Right.
Before we even get to physical illness.
Right.
We have to look at what happens when perfectly normal, healthy anatomy is simply perceived as a problem. And the clearest example of this right now is the massive rise in cosmetic gynecology.
Oh, wow.
Specifically procedures like labiaplasty, where healthy tissue is surgically removed for aesthetic reasons.
We are essentially living in an era where people expect Instagram filters to apply to their physical anatomy. It's wild. The pressure for physical perfection has reached the most intimate, hidden parts of the human body.
It really has.
But looking at the RCO guidelines, the Royal College of Obstetricians and Gynecologists, they emphasize something that feels like it shouldn't need to be said, yet absolutely does. They stress that there is a massive, incredibly diverse range of what constitutes normal vulval anatomy.
Huge range.
Right. Asymmetry is the default, not an anomaly. Different sizes, shapes, and colors are all biologically standard.
They are completely standard. Yet patients are walking into clinics deeply distressed by their own normal bodies. And the RCOG is very clear here. Female genital cosmetic surgery should be considered medically non-essential.
They don't pull any punches.
No, they don't. In fact, they don't even recommend offering it to anyone under 18 because the anatomy is still actively developing.
Okay, but let me challenge the guidelines on that point for a second.
Sure.
If a patient sits in a doctor's office and they are deeply unhappy with how they look, and it is causing them profound daily psychological distress, like affecting their confidence in their relationships, even if the anatomy is technically functional, isn't alleviating that severe psychological pain a valid medical reason to operate?
That tension right there is exactly what the BMA ethics guidelines grapple with. I mean, it is a physician's duty to relieve suffering. However, the data reveals a hard truth. Surgery is simply not a reliable cure for emotional distress. No.
Yeah.
The RCUG points out that the intense desire for these cosmetic procedures is frequently a displacement for deeper issues: general anxiety, relationship dysfunction, or just a fundamental lack of self-worth.
So fixing the body doesn't fix the mind.
Exactly. If a surgeon operates on a displaced anxiety, the patient wakes up with the exact same psychological pain, but now they also have permanent surgical alterations. That's why the guidelines recommend considering a psychological referral in primary care before a patient ever sees a gynecologist.
And the physical risks of the surgery itself also have to factor into that equation, right? Because these procedures are frequently marketed online as quick, simple cosmetic tweaks, like a lunchtime surgery.
Calling it a simple tweak is dangerously misleading. The tissues in that area of the body are incredibly sensitive and highly vascular, meaning they have a very dense blood supply.
Right.
The guidelines note that there is up to a 30% short-term risk of wound separation, clinically known as dehiscence.
Wait, 30%? That is a massive failure rate for a supposedly simple procedure. Why is it so high?
Think about the mechanics of that specific anatomy. It's an area with high moisture. It experiences constant mechanical friction from simple acts like, walking or sitting, and it's highly mobile.
Oh, that makes sense.
Yeah, so when you place surgical sutures there, the mechanical stress on those stitches is immense. Healing is incredibly difficult. And on top of the trauma of wound separation, there's the risk of severe scarring, chronic pain, and altered or entirely lost sensation.
Which can permanently impair sexual functioning.
Exactly.
Which means the doctor's role isn't just to say no, but to actively recalibrate the patient's perception of reality. And the guidelines mention specific educational tools for this. Things like the Great Wall of Vulva, which is a collection of hundreds of plaster casts of normal, varied anatomy, or the Labia Library online.
Yes, showing patients what normal actually looks like.
Right. Normalizing the normal seems to be the most powerful intervention available. Showing a patient that their body is already perfectly standard can instantly dissolve that psychological distress, entirely bypassing the physical risks of the scalpel.
Education is the ultimate preventative medicine in this scenario. But the conversation becomes significantly more complicated when we move away from perceived aesthetic flaws.
Right, because what happens when your anatomy is structurally perfectly normal, but it is causing debilitating functional symptoms? I'm talking about conditions like heavy menstrual bleeding.
Yeah, this isn't about aesthetics anymore.
No, this is a condition that completely derails a person's life.
It is paralyzing. I mean, patients are missing days of work every month. They become severely anemic. They're living in constant pain, and they're terrified of bleeding through their clothes in public.
It sounds like a nightmare.
It is. And what the medical data shows us is that heavy menstrual bleeding frequently occurs when there's absolutely no structural pathology. The uterus is completely normal.
That's so frustrating.
Or perhaps there are just microscopic fibroids, benign muscle growths, less than 3 centimeters in diameter,
Yeah.
that shouldn't logically cause that volume of blood loss. It's a functional issue, like a chemical misfire, not a broken structure.
So put yourself in the shoes of someone listening who is bleeding heavily for 8 days a month, utterly exhausted. If you are suffering that much, the immediate logical thought is just take the uterus out and be done with it.
Right.
A hysterectomy solves the problem definitively. Why is that considered overtreatment if it guarantees a cure?
Well, it guarantees an end to the bleeding, sure, but it extracts a massive physiological toll. The NICE guidelines on heavy menstrual bleeding operate on a principle called the escalation of care.
Escalation of care. Okay.
The clinical goal isn't just to magically stop blood loss by any means necessary. The goal is to restore the patient's quality of life while doing the least amount of bodily harm. A hysterectomy is major abdominal or pelvic surgery.
And taking out a healthy organ to stop a functional bleed is essentially using a sledgehammer to crack a nut.
Precisely. The uterus doesn't just exist in a vacuum. It acts as a structural keystone in the pelvic arch.
I hadn't thought of it like that.
Yeah, so removing it carries severe immediate risks, like accidentally cutting the bowel or the bladder, or severe pelvic infections. But it also carries long-term mechanical risks, like pelvic organ prolapse, where the bladder or bowel drops down into the vaginal space because that central supporting structure is gone.
Which means you basically trade a bleeding problem for a chronic mechanical problem.
Exactly.
So how do we treat the function without destroying the structure?
The NICE guidelines mandate, starting with highly effective, conservative, non-hormonal options. Medications like tranexamic acid, which directly targets the clotting cascade in the blood.
How does that work?
It stabilizes the fibrin matrix so clots don't break down prematurely. Or they recommend NSAIDs, like mefenamic acid.
And NSAIDs aren't just for the pain, right? They actually reduce the bleeding itself.
Correct. They work by blocking the production of prostaglandins. Prostaglandins are the chemical messengers that tell the uterus to cramp and shed its lining.
Oh, I see.
So by blocking those messengers, you reduce both the pain and the volume of blood flow. Now, if those don't work, the next step in the escalation of care is hormonal, specifically the levonorgestrel-releasing intrauterine system, the LNGIUS.
So an IUD.
Right. Instead of flooding the whole body with systemic hormones, this small device sits inside the uterus and delivers a localized dose of progestin, which dramatically thins the lining at the source, reducing bleeding for years.
But let's say the pills and the IUD aren't working, or the patient is experiencing terrible side effects and just wants to stop. This is where the temptation for a quick fix really sets in.
Oh, definitely.
Patients start looking at middle ground surgeries like endometrial ablation. It's often pitched as the perfect compromise. You get to keep your uterus, but they destroy the lining so it stops bleeding. It sounds like a simple outpatient fix.
It is frequently marketed that way, but the biological reality is much darker. The endometrium, the lining of the uterus, has two layers: the functional layer that sheds every month, and the basal layer underneath, which acts like the root system or the bedrock from which the lining grows.
Okay.
Endometrial ablation involves inserting a device that uses extreme heat, freezing, or microwaves to completely scorch and destroy that basal root system.
And when you intentionally destroy tissue with extreme heat, the body responds by creating scar tissue.
Extensive scar tissue. The walls of the uterus actually scar and fuse together. Condition known as synechia. And this is where the danger lies. First, the procedure has a surprisingly high failure rate. Between 5% and 16% of these procedures fail within 5 years, meaning the bleeding or pain returns, and the patient often requires that definitive hysterectomy anyway. But now it's a way more complicated surgery because of all the scarring.
And there is an even more terrifying risk hidden in that scar tissue from what I read.
Yes, the scar tissue creates trapped, sealed pockets within the uterine cavity. If a patient develops endometrial cancer later in life, that cancer can grow completely hidden behind the fused walls.
Wow.
It won't cause the typical early warning sign of bleeding because the blood is trapped, and it cannot be easily seen or biopsied on a normal ultrasound.
You are essentially boarding up all the windows of a house. If a fire starts inside, nobody can see the smoke until the entire structure is burning down.
This is a very good way to put it.
And on top of that, the guidelines mention that if any functioning tissue is left behind, it bleeds into those trapped pockets every month, causing a severely painful condition called post-ablation tubal sterilization syndrome.
Which brings us to a massive ethical dilemma. You have a structurally normal uterus, you permanently damage it to fix a symptom, and you potentially cause a nightmare 5 or 10 years down the road.
So what happens when a patient who has suffered for years and is utterly exhausted sits in the clinic and demands an ablation? They've read about it on a blog, they want a permanent fix, and they are basically begging the doctor to just do it.
This is where the BMA Ethics Toolkit provides crucial anchoring guidance for physicians. It states clearly that if a patient requests a treatment that the doctor deems clinically inappropriate, the doctor must explore the patient's reasons.
They have to listen to them.
Yes, they need to sit down and understand the non-clinical factors, the patient's exhaustion, their beliefs, their fears, how their job is being affected. But, and this is the critical part, ultimately, the doctor is under absolutely no obligation to provide the requested treatment.
It goes right back to the mechanic analogy. A good mechanic has to say, I understand your car is making a weird noise, and I know you're frustrated, but replacing the entire engine is going to ruin the balance of the car and cost a fortune for no reason. I won't do it. The BMA explicitly protects the doctor's right to say no in order to protect the patient from their own desperation.
It takes immense professional courage for a doctor to hold that line. We often think of overtreatment as bad doctors pushing lucrative, unnecessary procedures.
Right, like greed.
But very often, overtreatment happens because a compassionate doctor simply capitulates to an exhausted patient's demand for a quick fix. Excellent medicine is sometimes about tolerating the slower, less dramatic, and more frustrating process of finding the right medication rather than permanently altering healthy anatomy.
And the exact same human emotion that drives a patient to demand a surgical quick fix, the sheer terror of uncertainty, is what drives our next major trap, diagnostic overtreatment.
Yes.
It isn't just about avoiding unnecessary surgeries. It's about avoiding tests that cause more harm than good.
Diagnostic panic is a systemic issue, and we see this clearly in the British Menopause Society guidelines regarding bleeding while taking hormone replacement therapy. HRT is life-changing for many, but it can cause unscheduled bleeding.
And when that happens.
Right. The moment a patient experiences unexpected bleeding, the immediate overwhelming thought is it cancer?
And that fear of cancer overrides everything else. Let's look at the specific scenario in the BMS guidelines. A patient is on continuous combined HRT. Just to clarify for everyone listening, continuous combined means they're taking a constant daily dose of both estrogen and progestogen, which is designed to keep the uterine lining thin and prevent periods entirely.
Correct.
So if they experience bleeding, it's immediately concerning. The first step is usually a transvaginal ultrasound to measure how thick that endometrial lining actually is.
Right. and the magic number on that ultrasound is 4 millimeters. The guidelines state that if the ultrasound shows a uniform endometrial thickness of 4 millimeters or less, the post-test probability of cancer drops to a minuscule 2.4%.
Okay, wait, hold on. I have to stop you there.
Sure.
If I am the patient sitting in that clinic and you tell me there is a 2.4% chance I have cancer, I don't care that it's a small number. It's still a risk.
I hear that all the time.
I want to know for sure. Send me for the biopsy. Why on earth is my doctor telling me no?
Because the concept of better safe than sorry completely ignores the reality that medical testing is not harmless. We have to look at what happens when you push that patient onto an urgent suspicion of cancer pathway.
Okay.
First, there's the physical harm. To biopsy the uterus, you either perform a hysteroscopy, forcing a camera through a tightly closed cervix, or a blind biopsy where a thin tube called a pipelle is inserted to scrape the lining. Without general anesthesia, these procedures can be excruciatingly painful.
That sounds awful.
They carry risks of severe infection and even perforating the uterine wall.
And then there's the psychological trauma of being placed on a fast-track cancer pathway, waiting weeks in extreme anxiety. But there is a mechanical reason the blind biopsy is a terrible idea for a 4-millimeter lining, right?
Exactly. A 4-millimeter lining is incredibly thin. If you insert a tool to scrape it, you're essentially trying to rake leaves off a concrete driveway.
Oh, wow.
Yeah, there is simply nothing there to grab. So the vast majority of the time, the pathology lab returns a result that says insufficient sample. You put the patient through pain, terror, and risk for a test that essentially says, error, try again.
That's infuriating.
Meanwhile, you're overloading the hospital's cancer pathways, meaning patients who actually have highly suspicious 15-millimeter linings are waiting longer for life-saving diagnostics.
So if a biopsy is off the table, what is the correct evidence-based medical step when the lining is thin but they're still bleeding?
The BMS guidelines recommend conservative management. The bleeding is almost certainly not cancer. It's a mechanical instability caused by an imbalance in the HRT hormones. The correct medical step is to simply adjust the patient's HRT progestogen dose. Progestogen is the hormone that stabilizes and supports the uterine lining. You adjust the dose, reassure the patient, and wait 3 to 6 months to see if the lining stabilizes and the bleeding stops.
So you treat the function with a subtle chemical adjustment, and you tolerate a tiny amount of uncertainty while you wait. It feels completely counterintuitive to our modern scan everything, biopsy everything mindset.
It does, and it requires deep trust between the doctor and the patient. The doctor has to clearly communicate the mechanisms of why doing nothing or doing very little is actually far safer than doing something invasive.
So bringing all of this together, what does this mean for you, the person listening right now? How do you protect your own healthy anatomy from the trap of overtreatment at your next appointment?
Well, the sources give us a very practical toolkit.
The most powerful tool is a communication framework developed by the Academy of Medical Royal Colleges. It's the BRAN acronym, B-R-A-N. Whenever any test, procedure, or surgery is proposed, you must ask these 4 questions.
It's a great framework.
B is for benefits. What can I actually expect to gain, and what are the realistic statistical chances of this succeeding? R is for risks. What are the specific complications, like scarring or dehiscence, and how might this permanently alter my daily life? A is for alternatives. Are there simpler, non-invasive options, like adjusting a hormone dose, that we haven't exhausted yet?
And the N is the most critical question in modern medicine. What if I do nothing?
Yes.
Will my condition actually deteriorate, or will it just stay the same? Is observation a perfectly safe clinical choice? Asking your doctor what happens if we just wait 6 months is incredibly clarifying.
Another vital tool comes from the Cancer Research UK guidance on getting a second opinion. Do not ever worry about offending your doctor. The guidance explicitly states that good doctors regularly consult their colleagues on complex cases.
Absolutely.
If a physician is offended that you want another set of eyes on a permanent life-altering surgery, that is a massive red flag.
And finally, anchor yourself in the ethical boundaries established by the BMA. As a competent patient, you possess the ultimate right to refuse any treatment, even if a doctor highly recommends it.
That's empowering.
Interestingly, the guidelines note you also have the right not to be informed of certain risks if you explicitly communicate that you don't want to know, though that is rare. The core underlying principle is absolute autonomy. Your body belongs to you.
We've covered the spectrum today. We've looked at how perceived aesthetic flaws lead to destructive cosmetic surgeries, how exhaustion drives the demand for organ-damaging quick fixes like ablation, and how the fear of cancer drives painful, unnecessary diagnostic scraping.
It's a lot to take in.
It all traces back to our absolute intolerance for the body's natural malfunctions.
Which leaves us with a lingering, provocative question about the future. Right now, we're dealing with overtreatment based on symptoms we can actually feel. But as artificial intelligence and predictive genomics become standard, we're entering an era where a smartwatch or a genetic swab might tell you that you have an 8% predisposition to developing a condition 10 years from now.
Oh, that's wild to think about.
If our current anxiety drives us to permanently alter perfectly normal anatomy just to fix a heavy bleed, what happens when technology forces us to be hyper-aware of diseases we don't even have yet? Will we start preemptively removing healthy organs just to silence the data? As our technological ability to treat everything expands, our greatest medical challenge might be finding the discipline to leave well enough alone.
That is a staggering thought. Treating the data instead of treating the patient. It brings us right back to that mechanic shop. Just because they have the tools to tear the engine apart and the diagnostic computer says a belt might wear out in a decade, doesn't mean you should let them near the car. Sometimes, the wisest, bravest choice you can make is to recognize that the machinery is actually functioning just fine, put the tools away, and go live your life.